All right, welcome everybody to the Virginia Center for Diabetes Prevention and Education's webinar on using telehealth and technology to enhance your national diabetes prevention program. I'm Ann Wolf. This webinar is being funded through a grant from the CDC and that is through the Virginia Department of Health. So we thank them deeply for this. Oops. Let me go back. Thanks. So Mark and I are really excited to present this webinar, share our experience with you, and our learning objectives are pretty straightforward. We want to define this essential terminology that you'll need around telehealth and what it means, as well as what DPRP and how DPRP uses telehealth. Secondly, we want to review some of the evidence around using telehealth, not only for diabetes prevention programs, but also for weight loss, since that's a primary outcome. Third, we're going to be sharing with you lots of different examples of how you can use telehealth in your practice, in your organization, so that you can deliver your programs. There's many different ways that you can do it. And lastly, we're going to be really going through some primary questions and those considerations when using telehealth for diabetes prevention education. I'd like to now turn this over to our moderator, Rebecca Jolin.
Hello, everyone. It is my pleasure to introduce our presenters today. These two healthcare professionals have extensive experience with telehealth in the workplace and the National Diabetes Prevention Program. Ann Wolf is the director of the Virginia Center for Diabetes Prevention and Education at the University of Virginia. Ann earned her Bachelor of Science in Nutritional Sciences from Cornell University and her Master's of Science from the Harvard School of Public Health. Ann has been involved in telehealth since 2008 when she worked with BMIQ, a secure platform that helps dietitians and medical practices optimize obesity care through using technology. She's been actively engaged with the Academy of Nutrition and Dietetics, including serving on the Telenutrition Evidence Analysis Library panel, speaking about telehealth at the Level 2 Adult Weight Management courses, and developing a 4-part online learning module on telehealth. She has spoken to multiple groups about incorporating telehealth into their practice. Welcome to the webinar, Ann. Our other esteemed presenter today is Mark Bailey. Mark is the Director of Disease Management for the Innova Centers for Wellness and Metabolic Health. The centers provide endocrinology services and diabetes education and medical nutrition therapy. The centers are recognized by the American Diabetes Association for diabetes education and serve approximately 1,000 patients a month. Mark started his career as a registered nurse and went on to complete a Master's of Science in Health Services Administration. Since that time, Mark has worked in the hospital as a floor nurse in quality management and population health for health plans and has run outpatient medical practices. Mark is responsible for the diabetes program, which includes the Diabetes Prevention Program, which is delivered in person and by telemedicine. Welcome, Mark. We are so pleased to have you both presenting today. Just a few notes about today's presentation before we begin. If you are having technical issues, I will do what I can to help. My phone number is 434-982-0203. If you have an IT department on site, they could prove helpful as well, but I will certainly do my best to assist you should something go awry. Again, my number is 434-982-0203. We will be having a question and answer session at the end of the presentation. So when you have questions that arise during the webinar, please type them in the chat box. I will compile all these questions and we will go through them at the end during the question and answer time. To access the chat box, please take your mouse and scroll down to the bottom of the Zoom window that you currently have open. And you'll see where it says mute and video and participants, and you will also see an icon that says chat. So if you can go ahead and click there to open your chat box, and I'm going to write you all a small note. The chat box might pop up in a separate small window on your computer screen, and you can keep that window open the whole time or minimize it or close it and only open it when you need to write a question in it. You will also see that you have the option to write to everyone, or you can just scroll down to my name, Rebecca Jolin, and type the question directly to me. So please use the chat box to type any and all questions you have during today's presentation, and we will make sure to answer it at the end. Also, please keep your microphones on mute. Background noise makes it hard for everyone else to clearly hear the presenter speaking if the microphones are not on mute. So again, if you scroll down, you'll see where it says mute to the far left on the bar at the bottom. So microphone should stay on mute for the entirety of the webinar. This will ensure an enjoyable webinar experience for all. And lastly, for those of you that have phoned in, we will open up the microphones at the end of the Q&A for you to have the opportunity to ask questions as well. So please keep your questions on hand, and I will open up all microphones at the end, and you can speak to your questions at that time. So without further ado, Mark Bailey will be starting off the presentation.
Great. I am going to press control here so we can move along. Okay, let's move forward. So the first part of the presentation, we're going to go talk about just some key terms so that we all are on the same page and discuss these different modalities. And I'm having trouble moving forward, and I'm not sure if I have a delay or not. I have a delay. Thank you. So, so we're going to go through the Telehealth and National Diabetes Prevention Program and just, like I said, go over some key definitions. Let's try this again. Sorry, y'all, there's just a tiny bit of delay.
Mark, I can move them forward if it helps.
Okay, great. Thank you. So we've got two types of modalities that we generally use when we're doing telehealth. One is video conferencing, which is probably the one thing that most people are familiar with. It is actually somebody sitting behind a computer like me now, talking to you all live. Whereas mobile health can have many components. It can be simple as a web portal that people sign in and you share information, or it could have many components where you have people talking with, cell phones and tablets and doing classes through the mobile health application. But we'll get into more of that a little bit further along in the presentation. Can we flip forward? So the delivery modes that the DPP recognizes, there is 4: in-person, online, distance learning, and combination learning. Every time you take on one of these programs and you're going to deliver the DPP in one of these modalities, it is a single, you have to keep applying for an application for each and every one of them. So if it's in person and everybody's coming to your site and you're teaching, or you have your health coach there and all the participants, that's one. If you do it online using a web portal, that is another. Distance learning, it's when, of course, just like now, what we're doing now, that's another one. And then combination is a combination of any of the modalities that are here on the screen. Can we go to the next one? So online delivery mode. So this is what we were talking about with like web portals and how we can provide information to people and get information back from them. So the class is delivered 100% online. People log into a website. They can use a laptop, phone, any kind of Bluetooth technology where they can interact with somebody. And lifestyle coaches don't necessarily have to be live at the time when they're doing. Maybe parts of it are pre-recorded, parts of the online delivery mode is uploading weights from a Bluetooth scale, but the coach can be contacted either through mobile phones, regular phones, emails, texts. There's a lot to online delivery, and it can be very expensive. So while you're thinking about what you want to do, you've got to look at the cost factors as well. Can we go to the next slide, please? So distance learning delivery mode, we have the lifestyle coach, like I said, in one location. You have all your participants at another location, and you're using, well, we use a HIPAA compliant video teleconferencing modality called video, and it works very well. People really like it. And you can interact as like just having a regular conversation. Next slide, please. Combination, this is what we started with at Inova. We have patients coming to the center so that they can do their weights. Some people prefer, because a lot of the people that we provide the classes for are employees, and they have different shift schedules, so they will a lot of times participate online. But we can see each other, we can interact with each other. It's quite effective. Next slide, please. Leave it over to.
Great. Thank you so much, Mark. Great. I'm gonna
Oops, sorry, I lost my voice for a second.
There we go.
Thanks,
Okay.
Ann. Sorry.
Great. All right, so now we're going to talk about the evidence behind. So now you understand the definitions that CDC uses or the DPRP uses, and we want to begin to use that terminology, distance learning and online and combination, rather than other terms that we have used in the past, so that we're really aligned with what CDC does. Now let's look at the research and the evidence behind it of using telehealth for the delivery of NDPP, but also for weight loss, because we know that's sort of the primary outcome. So that's where I really want to start today, is taking a step back and looking at you know, what's really needed to be an effective weight loss program. You know, there's been a lot of research on this, of looking at what really promotes effectiveness. And we know that when we're doing the national DPP, that we want them to lose weight because that's what's highly correlated with the prevention of type 2 diabetes. And we know that that's what CDC wants, that we want to be effective. And we want this to be in our in-person class as well as distance learning or online. So it turns out in the literature, there are really 5 key components to it to have a really good program that works. One is self-monitoring food and activity. The second is counselor feedback and communication, and that really speaks to developing a relationship and the rapport. The third is social support. Fourth is use of a structured program. That's the Prevent T2 curriculum and having that structure around it. And then the fifth is using an individually tailored program. And that's really speaking to the coach speaks individually to the participant rather than just sending out general messages. It's really something that's more tailored to what they need. And we do this in our in-person classes. I know all of you here today say, yep, I do this in my class. We cover that. But how do we do this when we're doing distance learning or when we're using technology, the online technology? And in fact, it's very easy. It's very straightforward. So if we just go over to the blue box, you know, we can you know, through live video conferencing and even on the online platform, you can have counselor feedback communication. You can develop social support. So if I was giving a class to you, like right now, if you guys were all on mute and showed your faces right now, we would have a real group class going on, and that would provide the social support. In the online program, they have like online chat groups. That's how they provide that social support. We know we can deliver the structured program just like we're giving today's webinar, and we can individually tailor our messages and what we say to people because we can hear them. I mean, it's real time when you're doing distance learning is real time. And Mark and I will be spending most of our time talking about distance learning because, as Mark mentioned, the online platforms are expensive, and so they're pretty much out of most of our reaches. We're really going to be knowing that distance learning is what's most accessible to us. But the key component that's really missing here is one that we can do through mHealth, and that's self-monitoring food and activity. So using one of those online platforms such as Lose It and Fat Secret and MyFitnessPal. If you could all please mute your phones, please. That you using mHealth along with this really helps connect the dots and provides all those key components. mHealth is now, there's so many different apps out there. You can also help with, you could use apps like WhatsApp for counselor feedback and communication. For social support, you could use a private Facebook group. So technology is not limiting anymore. Technology, you can enhance how to deliver your class and provide those key components to optimize your weight loss. So the first question you may have is telehealth delivery of the national DPP as effective as my in-person? I mean, I love my in-person, and do I really want to do this? So if you all go to, if you're not on phone, if you're on video, if you're using video conferencing, take your mouse and bring it down to the participants panel. And when you press on participant panel, a separate panel will come up for you, and it will give you all these options like raise hand and yes and no, because I'm going to ask you a question right now, and I want you to respond using that panel. So take a moment and find that. And my question to you is, do you think telehealth delivery of the DPP would be as effective as in person? Go ahead and give me your responses right now. Ashley is saying yes. We have someone saying no. We have a couple yeses. We have more yeses. We have a few no's though. Okay. Thank you all. I appreciate that. Well, the answer to this question is it is as effective. I'm sorry, people that said no, but the evidence is pretty clear. It can be. And when I'm referring to, in this case, it's distance learning, just what we're doing right now. So there's a live synchronous component to this. Now, in this study, it was done by the the Montana Department of Health. It wasn't a study, it was an evaluation of their programs from 2008 to 2013. And they had been delivering all of their programs, all their DPPs throughout their entire state through the Department of Health. They used both distance learning and in-person. And what this evaluation did was just compare the effectiveness. And when they compared it, they found it was equally effective for attendance, achieving that 5% weight loss, and meeting activity goals. Both groups attended 12 sessions of the core sessions and 4 sessions of the core maintenance. Both groups, 56% achieved 5% weight loss. And in both groups, 47% met that goal of 115 minutes per week. So using technology does not have to mean that you have an inferior product at all. You can really connect to people. And I think both Mark and I will speak to that because we've been using it for so long, it really feels very natural for us. So don't hold back. Their keys to success that they shared with everybody was that the first one's pretty obvious. You want to find a remote site in a quiet location for the lifestyle coach. And they need to have the right technology. You really want to have a camera. If your computer does not have a camera, you can buy an external camera, which maybe costs maybe $25 to $50. It doesn't have to cost much. You can see, if you can see me, I have a headset on. And so that is one other purchase you can make, not too expensive, but you don't have to. You can see, you can hear Mark very well, and he doesn't have a headset on. So it does not have to cost a lot of money. The second thing, and this, Mark and I would also attest to this, is that having the lifestyle coach have an in-person visit to that remote location or having the people come to your location to establish rapport with the group. This is key. I have found this in my work with BMIQ, with my work in Albemarle County before I came here, that it really was important to establish rapport before going off to distance. And Mark, what Mark does is he brings them into the very first visit to review the technology so that they feel comfortable with it. So it is a key component to help them feel comfortable, but also to establish rapport. The third component is setting up the system so the lifestyle coach can really see the remote participants. Now, I won't ask you to turn your camera on today because it's lunchtime and you might be eating lunch. But if you'd like to turn it on, we'd love to see you. It's important. When you can see somebody, it makes a big difference. Third, having that coach respond to the journals, the food and the activity journals each week. And you can do this remotely through, they can either collect it and fax it to you, or you can use online platforms that connect the coach to the participant, and we can speak more to that later. The last one is having the telehealth site coordinator at the remote site. So because what Montana did, their model was to have one lifestyle coach broadcasting to 4 or 5 different sites around the state of Montana, each with 10 to 15 different people. So it was a very big class. And so they needed the coordinator there to sort of set up the room, weigh, to engage, and to do things like that. At the University of Virginia, we started off having that, but over the past 3 years, we haven't felt the need for it. People can actually weigh themselves and send it into us, and it's been working just fine. So you don't have to have that. It depends on your setup. So the next question is, well, how much weight loss can I expect from using telehealth to deliver the national DPP? Kind of a busy slide, but this is a composite from 26 different it was a systematic review of 26 different studies, and the different types of programs were vast. I mean, it was kind of hard to compare them, but you could break it down into whether it was an online only program as compared to an online program with some coaching, whether that coaching was remote through distance learning or whether it was in-person coaching. So what I want to bring your attention to is the final row here, to say that the least effective is when you do it online. And we have seen that with our programs, is that the least effective is just an online program when there's, when you have no personal contact. It does help when you have an online program that has remote coaching and when you're assigned one coach. And that's what we're seeing the online programs like Omada and Kappa Health doing. They're assigning a coach, and that coach texts with the person, and that helps. In our case, for distance learning, what it means is that we would be the coach, we are the remote coach, and then we would use online tools. So the remote coaching, if you look at the next 2 lines, you might say, well, the in-person is more effective. And that would validate those people who thought that online coaching wasn't that as successful. But in fact, there's no statistically significant difference between the remote coaching plus online tools and the in-person coaching and online tools. So they're really quite the same. You can use both. And I guess Mark and I can both really attest to that it's really effective. Next question we have for you is, how can I combine online tools to increase weight loss? And I know many of you come from a clinical background, so I want you to think of the diabetes medications. And we often will use diabetes medications with different mechanisms of action. It wouldn't make sense to use a diabetes medication with the same mechanism of action, because then you're just repeating the same kind of medication. Well, similarly to that, when we're using online tools, we want to use online tools that have different modes of action, so that they're not repeating the same thing. And that's probably pretty much common sense. So in the next study, they did this. And now, this was not a national diabetes prevention program. The outcome was weight loss. It's a very small program, but I thought it was relevant for 2 reasons. One, this is a very challenging population. Low-income urban postpartum mothers. Our OBGYNs and primary care doctors tell us how hard it is to get even postpartum mothers back into their practice after they've had the baby. It's tough. These ladies are busy. Now, add on to that, low income, it makes it even more difficult. So in this randomized control trial, what they did was they said, look, after the baby's born, after a couple of weeks of this is the time when women are not losing their weight. This is the time when we really need to start working with them on weight loss, but they're not coming back in. So we're going to randomly put them into one of 2 groups. One is our usual care group, getting them back into our with our provider. Provider's going to give them information about weight loss, as compared to a more technological approach. And in this approach, it was 3 different modes of action. Modes. One was regular text messaging. It could be done a couple times a week, and it provided that personal feedback and communication. Secondly was calls every other week from a health coach, again, given personalized information, but it was through the phone. The third was creating a social media, Facebook private group, so there was group support. See what's happening? They're meeting those criteria. The one that they really didn't include was doing sort of that online tracking of activity and diet. But I suspect that they would think that the moms would be overwhelmed by that, so they didn't add that in. But still, when you compare these 2 groups, there was greater weight loss in the technology-based intervention. That the weight loss difference, the technology group lost 3.2 kilos more That's 7 pounds more than the usual care group. That's significant. And more of them lost that 5% initial weight. So 30% of the intervention group lost at least 5%, whereas 0% of the usual care group lost 5%. So it can be very helpful to use these online tools in a way to maximize and optimize your weight loss. And with that, I'll turn it over to Mark.
All right. So now we're going to look at ways that we use telehealth to deliver the national DPP. There's many ways of using the technology that's available. So let me, Rebecca, you're going to move them forward for me again?
I sure can.
Thank you. I'm having a delay, I think, when I get it. So distant learning courses, you can have your educator, like I said, far away and have your groups in one area, or it can kind of be all spread out. But the thing is, if you're going to have a large group, and what we have found is that you need to have a moderator at that, or a moderator or an assistant to actually kind of get the rooms ready. Anne has already talked about this, but it's kind of important. It really builds kind of a camaraderie when you have somebody there. They know somebody when they get to the room. They're not sitting there by themselves waiting, and the room's set up and ready to go. And you can use that person too to help collect weights, collect information, and then make sure you're getting those data points that you need for reporting. Can we go to the next slide, please? So this is kind of the setup that the Montana group had used. What's great about this is that you can have, if you're in a rural area or an underserved area, you can set places up if you have a community center, a library, someplace where you can get a room with some internet capability and do this kind of teaching and interaction with groups. It's a little harder, like I said, when you have multiple sites like that, you really do need somebody at each one of the classroom settings to actually be there to assist getting everything set up so that you're kind of staying on time and on track. All right, we'll go to the next one. Combination live and distance. Again, this is what we use. This is what we started with. This was our first application. And this has been successful for us. We provide this service to all of the Inova employees. We have 18,000 employees. Most do a lot of shift work. So we had to figure out a way to be a little more flexible for people to get here. The traffic up here is bad enough for those in the Washington, D.C. area that it's very difficult to get even 10 miles away or 5 miles from one place to the next. You might spend an hour driving to come for an hour class. This was a very good way for us to get people involved and able to sign in on a lunch break or an evening dinner break or when they were at home. So it's very effective. We have found it easy to get the information from people. There is a little more kind of chasing people down on occasion to get the data points you need, but we find the delivery works very well for us. Can we go to the next slide? So this is just kind of a screen to show you that, you might want to do classes where, you do alternate. So you do a distance class one week and a live class the next week. I think a big part of it, and I think what a lot of people who use the telehealth, having the participants able to connect with their coach or see their coach is very, very important. And actually making friends with the people in their group, because a lot of times we have people that will go and do something, go on a walk with somebody else they've met in the group for support. Okay, next slide, please. So distance learning, so we've got participants at home. We use distance learning again for our makeup sessions. A lot of times it's easier to set up the appointment if somebody misses a class to actually get one-on-one and see them. They can talk to them. Again, they're building that relationship. And people seem to, having it online does not seem to hello?
Mark, you're back. We lost you for a second, but you're back.
Oh,
You
so
might, yeah.
this on this one here, this slide here.
Yes.
Oh, so what I was saying is that we use this for our makeup sessions. This is very effective. You still get that, you can do two or three people at the same time so that the coach is not having to say the same message over and over and over. Sometimes we have to do it one-on-one, but you still get that, even though it's online or over distance, you actually create kind of a bond with your participants still because they can see you. Okay, next screen. Distance learning for check-in. So Anne was saying she does this in between classes when we get to the longer breaks of, once every 2 weeks, once a month. This is kind of a nice way to do something to actually keep people engaged in the process. Doesn't take any time, it takes about a half an hour of time, but people are more apt to sign in and talk to you for a short period of time and just kind of check out where they're at. We do this sometimes. We offer a dietitian to come and speak for a check-in, optional check-in. And that is always very effective. Next slide, please. So the online, this kind of graphic here shows the web portal in the middle. So clients can log in, they get into the web portal, they can do a class online, they can read some information, they can upload information. They have the DPP provider on the other end. They can interact with them and talk. They can text. It's kind of a neat way of doing it. People can do it from all different areas. They just have to be able to access the portal. The problem with this, if you're trying to build something like this, it can be very expensive. Next slide, please. So live or distance plus online, it's a combination of everything. So this is just showing that you've got the web portal, you've got live people or people in distance, you've got your coach who's kind of moderating the whole process, and then you have the other people logging in from home. And it's kind of a nice way. It gives a lot of flexibility to both the educator and the participants. It does take a little more background to get it all together because there's a lot of moving parts, especially if you start adding in scales, Bluetooth scales or pedometers that are Bluetooth connected, and other web-based apps like exercise apps and things like that. And then I think we're practical application. We're back.
Okay, great. Thanks so much. So what we'll talk about now is sort of like, how do you start? What do you think about? And really what Mark and I are really sort of advocating for, again, is more distance learning rather than online, because it's an expensive endeavor to think about an online program. What we have capable right now is distance learning. And I also want to say that we haven't reviewed the evidence around mHealth that much. And the reason for that, I'm going to put a good plug in for, oh, thank you. My video is off. Sorry about that. What I'm going to put a shameless plug in for our NDPP annual meeting on May 8th, because we're going to have a whole panel around mHealth, so that we really held the mHealth for the May 8th meeting, which I hope to see you all there. So let's come on into, how do I start this? How do I get this going? All right, so what do I need to start distance learning? Well, you need a HIPAA compliant video platform. Yep, you really do. It has to be HIPAA compliant. CDC is very clear on the safety and security of patient information. We are delivering a health-based class, so we do need that. And Mark mentioned he uses video. We use Zoom. We've used Jabber. There's GoToMeeting, WebEx, Lifetimes. These are the online platforms. There are plenty more, but these are the online platforms that other DPPs around the country that are doing distance learning, these are the ones that they have used. So I just wanted to share those names with you. And what you do is you just pay a monthly or an annual fee to lease it, but you do need the HIPAA compliant version. And I'll talk about costs in a moment. Sometimes they distinguish by cost, the HIPAA compliant version, and sometimes they don't, but you definitely need one. And you need tech support. you know, I've done this long enough. It's so funny when using a new modality, there's anxiety. It's new. You know, think about your first class delivery. Were you kind of nervous? Well, that anxiety can definitely translate into IT problems. It definitely does. So having an IT person there for the first few sessions to support you can really take the edge off, and you can focus on the class rather than doing the IT types of stuff. So highly recommend support. The Virginia Center for Diabetes Prevention Education has also developed a distance learning capacity assessment form, which we are happy to share with you. And what it really takes through is it helps you to think through a little bit more steps. So you definitely need an online platform, I mean, a video conferencing platform and some support, but there are a few other things. And so we have developed a capacity assessment that really evaluates your organization's readiness, your organization's infrastructure, staff and participant training needs, and then the financial considerations, so that you're really making sure, is this right for my organization? And we are happy to share that with you. I have mentioned that we are grant funded through CDC and VDH to provide mentoring for telehealth. We have 6 sites that we're mentoring this year. We are happy to answer questions from any other site if you're up and ready to go, or you can sign up for the 2021 year. I already have one signed up for 2021. So we're really happy to help out in any which way, shape, and form we can. We're here for that. Okay, so how expensive is this video conferencing platform? I'm not making money from my DPP. How am I going to pay for this? There's a couple of ways. First of all, it's not that, it doesn't have to be expensive. It does vary depending, it may vary depending on HIPAA compliance. So I mentioned Zoom has a HIPAA compliant platform that costs $200 as compared to their usual non-HIPAA compliant, which is more like $12 or $15. That seems like a big gap. That seems like a lot of money. But GoToMeeting, actually all of their platforms are HIPAA compliant. For $15 a month, that's all it is. And you can so it doesn't have to be a bank breaker. My other tip is if you belong to a health system or a clinic, any sort of healthcare system, and I would even now probably say a university, check with your IDT department. They may have already leased out a HIPAA compliant video conferencing platform, so you don't have to buy anything. And that's what we do at UVA. We're not purchasing anything. We have Zoom automatically that comes to us. But we know they're going to be HIPAA compliant if they come through a medical clinic or a health system. They may or may not be HIPAA compliant if it's an organization level or a university. They're not always. So do check on that. You'll also need, because when you're using technology, every piece of technology, you need that platform company to sign a business associate agreement, or what we call a BAA, which brings me to our next question. What is a BAA? Do I need one? And the answer is yes, you do. So delivering a health program like this, we're a covered entity. That means that we have to make sure that our participants' data is secure. And kept, it's private and secure. Their PHI, their protected health information, that it's very secure. In person, we lock our files with that information. We keep it in a secure location. But when we're using technology, there's transfer of information across the web, and so it gets a little bit more dicey. You as a provider are responsible for their PHI, and that makes sense when it's in your hands and control, but when you're using technology, you will also be liable for the platforms to be safe too. So you need the platforms and the mHealth apps to sign a BAA so that you can so that you're not legally liable. And I was just looking at some things that I was saying. So for instance, Verizon, Skype, and Google, they will not sign a BAA. VC, Video, Healthy, Fruit Street, and GoToMeeting, Zoom, they'll all sign BAA. So, they're pretty standard now. Next question is, can I receive emails and texts from participants? Well, yes, you can. It took me a while to find this because everyone doesn't really want to say it. They're kind of keeping it very vague out there, but that's why I've documented this so well right here. You are a covered entity, but your participant is not a covered entity. They can share whatever information they want to share with you. And Whether their email is secure or insecure, that's up to them. So they can send it to you. Hopefully you have a secure email. And so once it's in a secure email, then you put it away. If you're from a community organization and your email is not secure, then once you get that piece of information, you want to delete it right away. So the other piece that I'd like to say is that because, you know, because of this lack of security, you want to disclose this lack of email security on their end with it and give them an option so that if they feel like, no, I don't want to send my weights and my activity minutes to you, that doesn't feel safe to me, they have that choice and they can do it through other, you know, they can call it into you, they can fax it into you, or maybe they do have an encrypted email. What I have found in general is that the participants in weight loss programs and DPPs have no reservation about sending this information by email at all. I mean, I've never had someone say no, but we as providers do need to you know, be careful about that and offer that. How do you collect session outcomes? Well, now that you know that the email is safe, you can just have them send you their self-reported weights. On an online program, it's self-reported. So on the distance learning, it can be self-reported as well. Hopefully your email's secure. If you want a little bit more validity, you can have them send a picture of the scale, and I think Mark has done this before. The online programs, some of them have Wi-Fi scales, but that gets to another level of complexity, which I wouldn't want you to have. And you want to have that disclosure in your consent form. Same thing with activity minutes, self-report. Attendance, if you're doing distance learning, you can see them at meeting times, so it's very straightforward and easy. For online, you can, for the online programs, there's usually a notification you can see, the coach can see how much video the person has completed, if they completed it all, and they monitor the text messaging. That's how they look at completion. Is telehealth delivery of the national DPP reimbursed? And the answer to that is yes, no. So the Medicare Diabetes Prevention Program is not, wouldn't you know I get a call right now, does not reimburse for distance or online programs. So Medicare, the NDPP does reimburse for in-person, but not for distance or online right now. But we just got notice this week that they are really deeply considering it. So hopefully that'll take place. But we'll have to stay tuned for that. But there are other options. You know, telehealth provides greater access and ability to scale. So, you know, there are other options out there for us. For instance, self-pay. I want you to think about all the programs that are online right now that people are paying on a regular basis. And sometimes we think for prevention programs, we hold back. We think, oh, people won't pay for it. But they certainly do pay for lots of online programs and lots of things. So don't discount self-pay. But one way I think there's a real opportunity here is to use distance learning to scale your program upward and make it bigger so that you can really provide programming for those self-insured employers. So self-insured employers are usually large employers who are paying all of their healthcare costs. They may use Aetna and Anthem to do the claims and the billing, but they get the bottom line. They pay the bottom line. And it's these self-insured employers who really want to who invest a lot in prevention and invest in population health because they want a healthier population to contain those costs that they ultimately pay. So think about this. You know, can you take your program, your in-person program, which right now you're struggling to do one program, can you expand it to a combo or to a distance learning program, provide it for a lot more people, and have a revenue stream coming in from employers? And that is what Mark is doing. And that's what we did at Albemarle County. So your self-insured employees, look at the county and the city employers. They are usually all self-insured. Okay. What are the challenges that you might face? Well, you need the necessary equipment, and it is going to cost a little bit, but it doesn't have to cost much. Most of us have computers right now, so it's not really a problem. An extra cost of a camera, maybe $25. Extra cost of a headset like this, $25. The video conferencing platform, another $12 a month. It's not, doesn't break the bank. The other challenge is that I find it really takes time for you to get to know technology. So many of you now are really used to this web-based meeting platform, and you're getting onto it much easier. But can you remember the first time you've done a web-based meeting, and perhaps how fraught with problems it was? And I can tell you, in 2008 when we started, we had so many technology problems. It just took us a while to get used to it. But people are, with FaceTime and Skype on our personal level, people are getting so comfortable using technology that they actually prefer it now. It's easy for them. The challenge is finding that IT tech person has really been a challenge for a lot of the people that we're mentoring right now. Just finding out who is that right person. So that's been pretty hard to find that person, but that's a challenge. You need to consider new ways to interact with the class. So right here, remember when I asked you to use the raise hand or the yes and no? So I can't do food samples with you and have you taste my food. I can maybe do a cooking instruction, but I'm definitely limited on the types of engagement I can do doing distance learning. So we engage in different ways, and so you have to think through your curriculum and engage in different ways. And last but not least, just please remember that distance learning and technology are not for everyone. What we're seeing is a high uptake on the younger population, a high uptake on people within the age range of 20 to 40, because they're very busy with their career, and young kids and stuff like that, they need the flexibility and they're very comfortable with technology. But as you get older, it is more challenging for that population. So, and we know that the Medicare population really enjoys that in person. So it's just not for everybody. Along with challenges comes opportunities. There are so many opportunities here. Can you imagine right now, how far are your people traveling to visit you, to visit that site? And how much of a barrier has transportation been for you? Amplify this three parts, and you can see you can reach people 2 hours away from you, 3 hours away from you without travel. So it really increases the access to your program. Secondly, you could increase that scalability. Think about how Montana, they had one lifestyle coach delivering to 4 different sites. That's what it took, so they could scale it upwards. It also gives us an opportunity to create partnerships and enhance capacity for other sites. So for the clinical sites, reaching out to federally qualified health centers and free clinics they don't have the manpower often to provide a whole national diabetes prevention program. So think about that. Not all DSMES programs have a DPP. Can you connect with them and be their provider for them? Because you don't have to be so close together distance-wise. It really helps. For the community organizations that are out there, there's so many community sites that you could connect with, like fitness centers and senior centers, to bring them in to provide your program with them. And then, of course, developing that partnership with local and large self-insured employers. And again, look for the county and the city employers because they're wonderful. So with challenges, there are also great opportunities. So in summary, the CDC allows online and distant learning modules, or you can do a combination. There's evidence to support it. There are many models that are possible. Make it happen for your group. It doesn't have to be one way. And there are things that we need to consider, but they're not back-breaking considerations. So with that, I'm going to turn it over to our moderator and open it up to question and answer.
Great, thanks so much, Anne. Well, looking at the chat box, we don't currently have any questions in the chat box, but we'll leave that open for a while. So what we'll do now is we'll go to the folks on the phone, and you can unmute yourselves, or I can also unmute you from here. If you have called in and you have a question, please unmute your phone, and Anne and Mark are available to answer.
And Kate, I'm sorry, Rebecca, can you put on the last slide? It gives us Mark's and my contact information as well.
Absolutely.
Thanks. Okay. So we have Lisa. Let's see. Okay. I'll let you.
I'm not sure how that happened. One second.
Okay, so Kate Jones is asking, can participants participate from home, or must they be in a center? Mark, you want to take that question?
Sure. So our participants do participate from home. They participate from work. We do ask that they go to a quiet room where they're not going to be interrupted or overheard by other people, since it is a group talking, and we don't want that information shared with people outside of the group.
Okay. Great, thanks. And then we have Lisa Miras. Do you need Zoom for telehealth platform, or is the standard Zoom platform HIPAA compliant? So Lisa, the answer to that is no. The standard Zoom platform is not HIPAA compliant, but if the Virginia Hospital Center has Zoom, I guarantee they must be leasing the HIPAA compliant platform or have access to it. They would not use it otherwise. So that's the big cost difference is for Zoom.
Here's one more. Oh, sorry, go ahead.
Okay. No, please.
Okay, from Ashley. For distance learning, how do you handle sound quality when there is a large group, multiple people talking at once, for example?
Mm-hmm. Mark, want to take that? Or?
Sure. So it does happen on occasion. That is kind of the role of the part of the role of the health coach is kind of saying, we'll take this question, then we'll come to you. We don't have a whole lot of background noise because, like I said, when we do that first visit, everybody comes to learn the technology. We go over that with them, kind of the rules, don't do it when you're driving, like all these things you find out after you've done one. We tell them you can't do it from your car when you're driving. You need to be somewhere quiet, someplace to answer questions or to talk. And then if somebody's talking, please wait till the next person comes along. All the people that are on the call can see one another, so they know when somebody's talking or when someone's not talking. So that helps a lot. But you do need your coach to act as the moderator.
Next question. Would a program that includes telephone conference call and email and texting be considered a distance learning program or a combination program?
That would be considered a distance learning program because they're doing live phone conferencing, right? But now it would be considered a combination if you had it one in-person visit. So if they came in once, even for like an initial or to visit, then that would be a combination. But if they're doing solely phone, email, texting, that is a distance learning.
These are great questions.
Mm-hmm. We also have something from Terry asked, can we get a copy of these slides? This is being recorded right now, and this will be available on our website, but we're not going to be providing these slides to anyone. I'm sorry. We're creating a Telehealth Village modules on this, and so we can't share the slides.
Sorry, one more question on sound quality. No apologies, Ashley. What about when connecting groups of people where they are in person and the coach is elsewhere? Is this where the on-site coordinator comes in?
Well, this is what we do here at WISE, at the University of Virginia, and actually Rebecca can speak to it because she's giving our current class right now over 6 hours away. So Rebecca, why don't you answer that one?
Okay, sorry. You know what? I was just texting or writing somebody back.
Okay, I can answer it then. I did it last year. I could answer it. Okay. So it's okay. Sorry I put you on the spot like that.
No, that's okay.
So it's really actually when they're in one location and the coach is far away, it actually almost makes it easier because they're self-regulating. They're looking at body language and they're self-regulating their times to talk, and you're watching everything, and so it actually works out when they're in one remote location and the coach is separate. Where it gets a little more complicated is if you have a class that they're attending from home and from work and there's an in-person class happening, because the people that are distance don't necessarily know when to speak because there's often a delay, or they don't want to interrupt somebody. So that's where there's sort of a hesitancy that can happen. But remember, we're here for a whole year, so what happens is that they get more comfortable with how to communicate.
Do we have anyone on the phones that want to unmute? Or if you're having trouble unmuting and see the chat box, if you asked me to unmute your microphone, I can do that. Okay, should I move on? Okay. Well, if you think of any questions or need any help down the road as you're setting up a telehealth program for your NDPP, please don't hesitate to reach out. This slide that's up contains the contact information for Anne and for Mark and for myself, and we are here to assist you always. A CPE certificate will be sent to the email you used to sign into today's Zoom webinar session. However, really important, if you have called in, please email me. And again, my email is up on the slide at rt9w@virginia.edu, and I will send you a CPEU certificate because otherwise I will not have your email in the system. Please let us know if you don't receive your certificate after about a week's time, and we will get you a certificate ASAP. The recording will be on our website, correct, Anne?
Yes.
Okay, a recording of today's session is going to be posted on the VCDPE website. So if you know of colleagues that were unable to join the live webinar today, they'll be able to access this valuable presentation on our website. We are so happy to have had you join us for today's webinar. And Anne and Mark, do you have any final words?
No, if you need anything, please just let me know. I'll try to help you out as best I can.
Yeah, same here. And it's easier than you think it is. Please don't let it hold you back. Don't be frightened of technology.
Oh, there's one more question. One more question. It says, are there apps that you use that are willing to sign a BAA, and also the coach can see a dashboard for all participants? That's from Ashley.
Yeah, these are the great questions. It's challenging to get the mobile health apps to sign the BAA. It is, and so it's it's tough. It's tough. There are. So the second question is kind of. Are there any apps we recommend that the coach could see a dashboard for all participants? And you're going to be learning about that mHealth app when we get to the March meeting. I'm sorry, the May 8th meeting. But for tracking, I'll say Lose It and Fat Secret, because they have a professional side, Lose It Ascend and Fat Secret Professional, where you can connect together and you can see people. So that would be it. But Rebecca will speak more about that at our annual meeting.
I will. I'm looking forward to it. All right. Well, on behalf of Anne and Mark and myself, we thank you for your time and your participation in the webinar today.
Thank you.